Welcome everyone to the She Can Fix It podcast, a monthly podcast consisting of interviews with female surgeons to highlight and empower the women of orthopedic surgery. My name is Dr. Alana Munger, and I'm a second-year resident here at Yale. On this episode, we have a fantastic interview with Dr. Liz Gardner. Dr. Gardner is a Yalie through and through. She did her undergraduate work here and played both lacrosse as well as field hockey. She did her residency here and is also one of the team physicians for Yale Athletics. When I came to New Haven from the West Coast, Dr. Gardner was one of the people who welcomed me and made me feel like I was part of the Yale family, which I'm very, very grateful for. It was truly a pleasure to speak with Dr. Gardner, and I hope you all enjoy our conversation. Dr. Gardner.
How are you?
Good. How are you?
Good, thank you.
Thank you so much for speaking with me, agreeing to talk with me. We finally set up a time in our busy schedules. Got it done. I was hoping you can introduce yourself to our listeners and describe your background, where you did med school, residency, fellowship, and all that jazz.
All right, so I started a little bit before that. I grew up in New Hampshire, so that's a big part of who I am, just being from sort of rural, small town. Made my way down here to New Haven to Yale as an undergrad, where I was fortunate enough to play field hockey and lacrosse during my time, and that obviously, to get further into, has really impacted what I do now and why I'm here and why I'm so passionate about it. So after spending 4 years here playing sports, pre-med, that sort of thing, I took 2 years off and went to the UK for a couple years and was actually a boarding school teacher at a old school founded in 1556, got women like 5 years ago sort of thing, right. Boarding school in England. So I taught science and coached field hockey and just really had some time to breathe and grow up and really sort out what I wanted to be, because everything I'd done to that point had been about planning for the next step and getting there. And this was the first time that I really, I knew I wanted to go to medical school, but I got to step back and really work on some of the things of me as a person, not doing homework all the time and not preparing for the next test, but really kind of saying, okay, what do I need to do to be a better doctor? And a lot of that was communication and growing up and not being a professional student. And so I did that for 2 years and probably could have stayed there very happily in a nice little, Harry Potterville.
Right.
But ultimately came back home and went to medical school in Atlanta. Really wanted to get out of the Northeast where I had grown up. I had a very narrow sense of this country, and I was abroad for 9/11, and that really was an impactful event, but I was the only American in town, and this happened within 3-4 weeks of getting there. And so my identity of being an American and who I was, I realized I didn't know that. I'd been around people who were just like me my whole life. So went down to Emory with the purpose of living in another part of the country and seeing a different part of America and understanding what all that was, and really chose it for Grady Hospital and the opportunity to be in a place where medical students are not supernumerary at all. But if we weren't there, stuff didn't get done and patients didn't get taken care of. And so it really was a phenomenal opportunity to be in that environment and be hands-on and be an essential member of the team as a medical student, which I'm not sure happens. I mean, that wasn't every rotation, but I don't think that necessarily happens everywhere.
No, it's true.
So knew I wanted to do orthopedics. I was that person. Frankly, I decided I wanted to do orthopedics freshman year of college, but it's fine. But so I was that person all through med school who really knew what they wanted to do pretty narrowly, and then was fortunate enough to come back up to Yale, where I reconnected with Peter Jokel, who had been my undergraduate thesis advisor, and I actually started working with him my freshman year of college.
Wow.
So, So down a lot of the nurses in our clinic were down there, back in the late 90s. And so as a freshman, and spent my summers working down there and really understanding what that was. And so I was fortunate enough to reach out to him, came back up here for residency. Phenomenal experience that you're going through at this point.
Indeed.
I'm sure every moment of it is phenomenal. The glasses get rosier as you need, but really, Same sort of thing. Wanted to be in an institution where my hands were going to get dirty and where residents really were running the show. And I had that without a doubt. Went out to Michigan for my fellowship. Wanted to see college sports on the highest level. And so major program where there's no expense spared, recognizing that my goal was ultimately to come back here to Yale and grow this program and really turn athletic medicine and sports medicine at Yale into the academic program that it should be, because we have all of these resources around us, and that's so much of what I think makes sports medicine cool, and how we're pushing the envelope and providing the student athletes the best care is by utilizing everything we have around us. So came back 7 years ago at this point from Michigan and been here ever since.
I know. And you talk about being a student athlete, and you were a 2-sport student athlete, which I think is absolutely amazing, because I was a 1-sport student athlete, and I'm just like, I can't even imagine doing 2.
Different.
Yeah, but it's insane. And I think what's amazing was that there was a paper published from the Mayo Clinic that was published in the Yale Journal that actually investigated grit and perseverance and conscientiousness. And what I think is the first thing that I thought was hilarious was the fact that grit was measured by a questionnaire, which is amazing.
Yes.
But it actually found that former student athletes had more grit and perseverance than those who did not play varsity sports in college. And the study also found that females demonstrated more grit and conscientiousness than their male colleagues. So do you think that your life as a 2-sport varsity athlete here at Yale prepared you for medical school and residency and beyond?
Absolutely. I mean, I think, what you go through, you lived it. It's challenging. It is a full-time job to be a student athlete at the Division I level. And things are different now, looking at how you do 2 sports and that sort of thing. Things are different now. But just being able to find that balance. I mean, I remember it was essentially, it's about 8 hours out of your day when you calculate what it is between getting lunch, getting out to the fields, getting taped up, warmed up, whatever treatments you have to do, doing your 3-hour practice, coming in, sitting in the ice bath, getting yourself back into dinner, and so those 8 hours are gone, and then you're also so dead now you can't keep your eyes open. So not only have you lost that time, but you are so physically exhausted that the thought of now, hunkering down to do your orgo P-set is just...
Not in the mood.
Not in the mood, exactly. And so, but you sort it out.
Right.
And so I think you get creative, and I think that you really, you find that grit, you figure out how you work. And I think that's a lot of what grit is about, is everybody's a little bit different in how they approach it, but it's kind of just the get it done factor. And you can't write a script. It's hard to give people much advice on like how do you be more grit. You got to sort that out on your own. And some of that is just, the forced adversity and self-imposed adversity of, the time constraints, but also just there's ups and downs in sports, and there's injuries, and not every game goes well, and how do you deal with it? I remember having on the front, well, it was the back page because that's where sports were, but the headline of the article when we lost to Harvard in field hockey one year is, well, we would have won if Gardner had marked her girl.
No.
And true statement.
Wow.
Like it's how do you deal with that?
Yeah.
And you're getting called out, and you learn to not take things personally. And I think as you then get into medicine, and especially a field like orthopedics, where it is a bit more male dominated and things are perhaps a little bit more directly communicated than, women may do, good or bad, that you just kind of learn to not necessarily let it roll off your back, but you learn how to take what you need for feedback out of that and then move on from it. So no, I think I couldn't agree more with what the study says. I think we see it. There have been plenty of studies that have looked at, if you look at corner offices and Fortune 500 companies and female CEOs, and that just the preponderance of former student athletes in those roles. And so we see it in medicine, we see it in surgery, and we see it across other kind of high-powered fields. There's whether they draw similar types of personalities, and that's probably because athletics has has grown and developed that in us.
Yeah. Have you been able to mentor female student athletes who are interested in medicine? Do you see them? Are they coming through the ranks, or is it just kind of like they're not there?
So I do see them. And so, interestingly, the way kind of my life at this point in sports medicine and my involvement with Yale athletics is I spend the majority of my time with male athletes.
Right.
Contact sports, that sort of thing. But no, I mean, I have several undergraduate advisees, some who were formally assigned to me, and others who, get emails from here and there. And it's very cool to sit down and be able to bring them into the OR, even just sit for coffee and kind of almost, kind of have this conversation of,
it's a possibility.
It's a possibility. And I mean, it's so weird to think that, that people are still wondering whether or not you can find that balance, whether or not you can be a student athlete and be pre-med.
Yes.
To which my answer obviously is yes, but you have to got to get creative. You can't be doing that in 4 years is very challenging. Yeah. And so then the other side of it is it's also still surprising that not everybody feels that they see that around them. And
True.
I think in our world here, fortunately, in our department, we have we have female orthopedists around, and it is not a uncommon
occurrence to see something.
Right, and it's weird. It's this world in which we forget what the outside views us as. Every once in a while, I'll get on the phone with a parent, and we get chatting, and they get comfortable, and it'll come out that you're the first female orthopedist I've ever spoken to. And that's just that's astounding in 2019 that's the case, but we live in a little bit of a bubble up here. Yeah. But that's the goal. Grow the bubble.
Grow the bubble.
Grow the bubble.
Grow the bubble. That's amazing. And so I know that you knew from an early age that you wanted to be a sports medicine physician. Was it simply because you played sports, or what is it that drew you to being a sports medicine surgeon?
So I think when you look back at it, so I was fortunate enough that I was healthy growing up, my family was healthy, and so we don't have any doctors in the family. So the only doctors I ever had to know were orthopedists through sports injuries. And so that was kind of medicine to me aside from my pediatrician. And so got here to Yale, obviously knew I liked sports. I'm 5'2" on a good day and play two sports. Now there's a professional lacrosse league, but that didn't exist back then. And so realized the fact that, if you asked me, my identity was as an athlete. All this medicine stuff and everything else was completely second. I was an athlete, and that's to this day. That's still who at my core I feel like I am. And figuring out a way to continue to be a part of that world was really my goal. And I loved teaching and I loved coaching. The 2 years that I did it, I was pretty good at it.
Right.
But that wasn't going to be what I was going to do long term. So as I always thought about it, came back, I was good at science, I enjoyed it, and then I saw what impact sports medicine doctors had, and it really was Dr. Jokel. I spent every summer with him in college, first just shadowing around the office, walking. Barb was there.
Oh no.
Yeah.
Love Barb.
Yeah, love Barb. So, and that was back kind of in Yale sports medicine was a bigger deal then. And I remember being there one random day when Dr. Jokel got Sir Roger Bannister's hip x-rays, mailed him from England, because this was like 97 or something like that. And just looking and listening to him talk about it and just how methodical it was. And that then started to fit a little bit of that piece of my personality where it's fixing things and it's facts and structure and tangible goals and tangible things and tangible solutions, not management. Fix. Yeah, works for this, doesn't it? So, I mean, it became a way to support the next generation of student athletes in the way that I then felt like I had been supported. I had a lot of injuries. I had 5 surgeries while I was an undergrad. I was booted for like 4 years for shin splints and stress fractures and stuff. So I made it. 8 seasons, got through it, but that was because of my athletic trainers, who I'm still very close with, strength and conditioning coaches, Dr. Jokel, all of these people, the team, the athletic medicine team here is why I got to have that experience. And so the opportunity to support current athletes and to lead that team, be part of that team to make sure that this 4 years that they have on this campus, or weekend warriors and quality of life and high school, all levels, just knowing what an important experience it is to be able to step on that field or court or whatever it is. There's just nothing better than that. Yeah. So anyway, that's where that came from.
That's
so
amazing.
It's kind of the cheesy story.
No, I support it.
I didn't tear at least I'm not the ACL story.
I know, you're not the ACL
story.
story. I'm like, yay. Oh my word. Can you describe to our listeners what it is that you as a sports medicine surgeon, what it is that you do?
So I think I don't know. Things are evolving with lots of different levels and different types of providers, musculoskeletal providers. So, but I think, as a sports medicine surgeon, in some ways we have been the general practitioners of orthopedics for a long time.
Right.
So we really see in the, adolescent through upper middle age-ish, really all the different types of wear and tear injuries, acute injuries, bumps, all that sort of thing. Certainly now as you look at it, it's becoming, I think what most sports medicine surgeons are looking, it's more acute injuries, sport-associated injuries, but both surgical and non-surgical. And I think that's something, I don't know whether I can't be old school 7 years into practice, but maybe I'm old, but I enjoy having a conversation with patients about non-surgical aspects of this. I get a kick out of looking at somebody with hip pain and having them take off their shoes and talking to them about how their flat feet are affecting their knees and are affecting their hips and that. So, I mean, I think what we do is we keep people active, and whether that's non-surgically with activity modification and looking, spending a lot of time looking at alignment and form and movement patterns and, working very closely with physical therapy and, trainers and that, all the way through surgical injuries, which obviously in everybody is going to be a last resort, but in a lot of athletes, right?
You gotta do what you gotta
exactly.
do. Yeah.
And so then it's the structural side of things. It is taking some structure, tendon, ligament, whatever that's torn, and bringing it back as close as you can anatomically, and again, then coming back to work with that team. So I think the thing that I love the most about sports medicine, and obviously every doctor is part of a team, but I think a sports medicine surgeon is really a part of a team. I say to ACL patients or anybody, I'm important to you for one day, and that's not total, but I will do my absolute best job for you on that day to set you up for success. But then, it's the patient, it's the physical therapist who's working physically, but also working as their psychologist.
Right.
It's the team, it's their support team, around them, whether it's their parents or their sibling, whatever. It's so cool to be one piece of that puzzle, because that also then means you are constantly learning from all of these other people. So every day things are evolving, and every day we approach things a little bit differently. So I think I got a little bit off of your question here in terms of what I do.
Love
I don't know
That's
if
great.
that answered it, but
it did.
Yeah. Okay. So
so you talk about the benefits of being a sports medicine surgeon. What are some of the challenges that you face in your field?
So, I mean, it's obviously a very competitive field. There are lots of people who, even within the surgical field, lots of people who do arthroscopy who aren't necessarily sports trained. Within the greater field, lots of people call them sports medicine doctors now. So I think it used to be that you said sports medicine, that was synonymous with an orthopedist.
Right.
And that's not the case anymore. And certainly, that there's good reason for that. And, the field of medicine has just exploded, and there are so many. Sports medicine used to just be about bones and muscles, and we didn't really understand all these other more like medical components to it. Right. And that goes beyond our level of expertise, and it goes beyond what any one person can learn and train for anymore. So that team is growing, But I think that's a challenge, and I think that it's as roles get defined, and perhaps that's a little bit more within each individual unit, but just really figuring out who's the best person for each case and each patient and how you work together. It's the best and worst thing. Mm-hmm. As I said, you're constantly learning, but there are different schools of thought, and surgeons, again, we got a hammer, everything's a nail, and it's an interesting dynamic, and I think that that's ebbing and flowing all over the country, as different types of musculoskeletal providers. This probably isn't a great conversation to include. I'm not going to say holding our turf. That's not the right thing to say. But no, it's a growing and at times crowded field, with lots of opinions. And so when it comes to dealing with patients, and especially with athletes, it gets crowded. And keeping not control, but just keeping tabs on everything that's going on and making sure that everybody is indeed working in the best interest of the athlete can be challenging at times. Because these are who everybody wants to take care of, right? I mean, this is they're fun, they're driven, they're motivated, and most of them are going to get better. And so it's it's the best population in the world to deal with, but again, it comes with the challenges when you have lots of cooks in the kitchen.
And I remember you mentioned the fact that there was a patient's parent who had said you were the first female orthopedist that they had spoken to. When you came back here, or even if you could talk about, was it difficult to get the respect and the trust of patients, your student athletes, as well as parents?
So certainly having been a student athlete here was invaluable. And I think that and not just here helped extra, but having been a student athlete, I hear that all the time from coaches or athletic administrators or parents or even kids. When I get introduced, or if somebody's kind of almost trying to I'm being introduced and they're trying to suggest that I'm good at my job, it's, well, she played sports here, she gets it. It's that, it's that she gets it factor. That I think that was essential. I think it would have been, I can only imagine how difficult it would have been to come in as a woman, especially into sports like football and lacrosse and that sort of thing, not having had that aspect of it. But I think that's probably fair, actually. I'm incredibly lucky that, as we've said, around these parts, a female orthopedist is not unheard of.
It's NBD.
Yes, right. Well, in the university, you go outside of the university in private practice, there is not as many people around. And so, but I was lucky that when I came back, the athletic director at the time had been my athletic director. And so he knew me when. And he had heard, I had spoken to him. He had been a mentor of mine over the years, knowing what I was looking to do and hoping to grow our program. So he knew how passionate I was. So that I was incredibly fortunate there. And then as we've transitioned in, I mean, we amazingly now have a female athletic director. And so that she and her staff have been spectacular, because again, same thing, just not an issue. On the field, the coaches have been unbelievably welcoming. And I think I wasn't handed any of these sports. When we started taking care of the Yale athletes, I was the absolute low man on the totem pole and had none of the responsibilities that I do now. And so it really came with finding a place to make my name. And that's what I did. And so I think at that part, really having grown very organically rather than having been dropped in someplace and everybody being told, this is your person. Oh, and by the way, she's a woman. It just started to find a place where I could make a difference. And through that, it became a non-issue because frankly, I was doing the job and doing it well. And yes, get on the phone with a parent and they don't realize that the Dr. Gardner their son has been talking about is a woman.
Right.
I mean, it's the same. You walk into a patient room and it's the like, huh. Yeah, and you do. And sometimes it gets verbalized.
Right.
It's like, yeah, nope, that's me.
That
Here
is
we
me.
are.
Yes,
Still
Dr.
good.
Yeah, right here.
But so yeah, you still see it, but I think because it came about really, and I just slowly earned that respect, and I knew how the job should be done. I had trained very hard. I mean, it was a conscious decision to go to Michigan, and it was a conscious decision to work with Michigan football because you get some street cred from that. And I didn't know whether I was going to come back and work with Yale football, but there was a cachet there that had said, look, I know I didn't play your sport. By the way, most of the men taking care of you guys have never played your sport either, but that's its own deal. How could I possibly understand football without having played, right? So, but I was good enough to go work with Michigan football. And they have no idea how that process works or anything else.
Right.
That was my choice to do it. That was not theirs, but my choice to do it. That to have that on my resume, to be able to wave that flag every once in a while when I needed to early on, and just kind of say, well, at Michigan, this is what we did. And you're good.
Yeah.
And again, I'm not a man. I have no idea how it goes on the other side of things, but I was very conscious in my choice, and making sure that I had those check boxes there checked, so that I thought I'd need to come back on them at some point. And so again, I've been fortunate that has worked out, and then it just became taking good care of the kids.
Yeah.
And here we are.
Here we are. And so I do want to transition our topic of conversation and talk about imposter syndrome.
Yes.
This is something that you and I have talked about before.
Yes.
In that imposter syndrome, for review for our listeners, imposter syndrome is that feeling that you don't belong at the table. You don't deserve that job. You don't deserve that award. I remember, right now we're in residency interviews, and I remember getting those emails, and I'm like, wait, I don't deserve this. I shouldn't be getting an interview at that school, And I think, I just wanted to talk to you about, do you think that female surgeons also succumb to this imposter syndrome?
Yes. Yeah. No, I mean, again, we have talked about this, and I do. I think it's real. I definitely still succumb. I feel like it's getting better and better, but there is still just every once in a while that deep down question of, am I going to be found out? I think that's the feeling that every once in a while I have. And it's interesting how it gets triggered by certain people. I had an instance not that long ago in which we were in a conference talking about things with some people who I've known for a long time, both male surgeons, and something brought up that I do something surgically different from the way that they do it.
Yes.
And I got it like
panic moment.
Panic moment. I shut up very quickly because I was completely convinced I'm wrong.
Right.
And we moved on, and then went home and texted every single one of my co-residents and co-fellows and everybody who I know who still does this surgery, and just said, and to the extent that I didn't say what I did because I was still so convinced what I did was wrong, and then I was going to be found out by these other people.
Yeah.
And so it was hey, so what do you guys do with this? And everybody replies back exactly what I do with it. And we had a nice little conversation and talked, okay. And then you come bouncing back when it's like, oh, yeah, no, dude, I totally know what.
Yeah.
But there it is.
Yeah.
And it gets triggered, and I haven't had that in a while.
Yeah.
But it was really knowing we were going to be having this conversation, and having Erin, who's one of your co-residents, female, resident on the service right now, we got talking about it in the OR.
Right.
Because it's, when does this go away?
Yeah.
And I certainly remember it happening all the time.
Yeah.
In residency, but then as I got more and more comfortable, by chief year, things were good. I felt like I belonged. I felt like people trusted me.
Right.
And then came back as an attending, and
right
back into the when am I going to be, I can't possibly be as well trained as everybody else. I don't know as much as everybody else. Yeah, when am I going to be found out for, like, people like me because I can chat and fun, like hang out and like I can talk about stuff. But like when it comes down to it and when you're the person like on the line making the medical decision, who's going to operate on my child, I gotta say, like, it's still my default is a little bit, and it's default, I at this point I call it my style, and I think it's probably something that's more women's style than men, but it's just to be very self-deprecating about it, and very much like assume, nope, your child, probably gonna want your child to have surgery, at home, and I understand that, as opposed to, most male colleagues who I think I know, who would lead with the default being, I'm your guy.
Right. No, it's so true. It's so true. Like, especially like what I notice is like I'm on consults right now. And so whenever I make a decision and someone says, well, why did you do that? And my immediate thought is not like I have 100% confidence in what I did, even though it's 100% right. And the patient's great for it, My first instinct is like, oh no, like what have I done? But at the end of the day, it's weird how my first thought is not, oh my God, no, I'm 100% right. It's that like, well, what if?
Right. And not to turn this back on, but do you notice that is a different reaction, whether it's a male or female asking you that question?
I have not thought about that. But no, I think you're right. Because usually it's more like a discussion. Well, like, because it's more of a like, so why would you do that? And I'm like, well, this is what I was thinking. Where if it was one of my male colleagues, I'm like, well, now that you're mentioning that, and I'm just like, it's a different conversation.
And it's hard. I mean, cause I feel exactly the same way. Even if we're in the OR and somebody asks a question of like, why you do it this way or what about doing this, and I don't think I can totally put it on the person delivering, their tone or approach, anything like that. I mean, I think a lot of that is how I interpret it, and I feel it. Yeah. I think there's a part of me that feels it a little bit differently. Yeah. Depending on who it comes from. Yeah. And
how do we tackle this, Dr. Gardner? How do we Oh my word.
Let me know. I know. But it does, I mean, certainly what I've noticed is what's nice is when you go to those places, I think the more times you come back and feel validated, or the more times you question yourself, but then, whether it's something that actually has gone wrong or when you then get that positive reinforcement both for yourself but also from other people,
right?
That's where it starts to be like, okay, like I do fit. Nobody's perfect. I do know what I'm talking about. Yeah, but every once in a while. A couple weeks ago, I was like, how are we back here?
I know. Awesome. So I do want to talk about being the only woman in the room. And as you had mentioned, you're kind of had experiences where parents tell you, you're the first female orthopedist I've seen. And I remember I've had a moment where I was doing a hip reduction and I felt this enormous pressure of, if I do not reduce this hip, one of my male colleagues could have done it. And people are going to think, oh, it's just because she doesn't have the strength to do it. And even in this situation, this ED attending was literally like, do you want me to like hold the leg? And I'm just like, and it's, sometimes I feel that like the entire gender, like all female orthopods are on my shoulders in this one reduction. And I was wondering if you ever have that same feeling as well, where you're just like, well, got to do this for the gender, got to do this for the lady pods.
Absolutely. No, I mean, I think, when I was coming through residency like you, I mean, we were fortunate that we had a number of female residents. Right. And so, lots of people had different styles. We were all very, very different. But you learn those tips and those tricks from the older residents, older female residents. Because it is that, I think the benefits in some ways of being a female resident is that, like, if you're killing it and doing great, like, it's extra easy to shine. Well,
Right.
not easy to say, damn, yeah. But, but it's
deservedly
different.
so.
Yes, exactly.
Yes.
But it's noteworthy, and there gets to be attention drawn to that. But on the flip side, you're right. You are representing, seemingly and stupidly, but de facto representing all women who are doing this with your one reduction.
Right.
And it's completely asinine, but I think we all feel it.
Yeah.
And so, it is needing to be perfect all the time, because if you're doing it well, you're basically just doing it as well as the men are.
Right.
And then if you're not, forget all the reductions that they couldn't get because they're irreducible or because they're idiots and pulling to, whatever.
Right.
You couldn't get it because you're not strong enough or something that is the stereotypical,
Yes.
attribute to a man that a woman couldn't possibly have. And so, no, I mean, I think you see it certainly being in football, in contact sports, and that. I do. I mean, it seems like, I'm very lucky that I feel extraordinarily well supported here.
Right.
But I always do wonder what would happen if there were somebody running up my coattails who's, of the other gender.
Right.
Who comes in and all of a sudden I can't do something, or something doesn't go exactly as planned, or whatever. Is it easier to default on over to the man,
Right.
even in this situation? Right. So,
yeah. Does it get better?
I think in some ways, I think it feels different. I mean, I think the responsibility I feel to certainly younger female orthopedists, residents,
Right.
med students, undergrads, that sort of thing, is that responsibility to me is growing, and that burden is not it, but I feel a great need to help.
Right.
And so I think some of that is it's less that they're on my back with every clinical decision I make, but it is more that showing them and being that example. And so, so I don't feel the weight in the way that you do, which I totally remember in the ER, in
Right.
every single way.
Yeah.
Right, because it's the hip reduction that you don't get that gets talked about, not the guy who completely skinned the 85-year-old woman's hand because he was a moron when he reduced her distal radius.
Right.
No one talks about the fact that that was wrong.
Right.
And then you turn and look at the hip and it's probably was irreducible.
Yeah.
So it's different. I think it evolves, and it becomes less about your individual clinical decisions. But also that's because I'm in a place, as I said, where I do feel incredibly well supported, and that I don't feel like being a female orthopedist day to day is a thing.
Right.
Which is incredibly fortunate.
Yes, we are very, very lucky. So speaking of Yale, speaking of Yale athletics, what are your future goals and projects, just in terms of both in the hospital as well as outside the hospital?
So, I mean, I think, we're in exciting times. We have a new female chair, which is very exciting. So I think, there just really is there's a renewed sense of energy and a sense of direction in terms of where we're going at this point. And, I am very hopeful and optimistic that really growing sports medicine and athletic medicine is a part of that vision. Looking at, as I've said, looking at, to me, the way you do sports medicine better is by less about the surgery. Yes, there are technical pearls and things we can do and always trying to make advances, but a large part of what we're doing surgically is actually not that difficult.
Right.
You need to do it right, you got to put the tunnels in the right place, you need to repair the tendon well, but really the art of it and where you have the ability to affect patients' outcomes as well as to drive the field is in everything else that surrounds it. Right. So what I'm looking forward to and what I hope we're moving towards is really much more of that academic team approach, both for sports medicine as it means kind of as an orthopedic field, but then athletic medicine as it relates to the athletes as well. And how do we how do we have that team that we have for the athletes? That's been kind of my little petri dish for the last few years, where we've been able to build a collaborative team of strength and conditioning and athletic training and physical therapy, and we do lots of different types of testing and functional testing and injury prevention and all of these sorts of things on a small scale. How do we scale this up? Because that isn't something that's just applicable to a D1 athlete. Like, one, we can do that better.
Right.
And then number two, that's what sports medicine for everybody should be. And that's how probably going to have less surgeries. It's how you're going to have happier, healthier patients with better outcomes is not going to be by me standing out there yelling that I do the surgery better than somebody else. It's going to be by having that integrated team around us where from day one, everybody's on the same page and we're not passing patients back and forth across town. We're all there together driving the care of that patient, and we all have equal ownership in that patient's recovery.
Right.
So that's where I want to go.
I love it.
Cool.
Now, the final 5.
Yes.
This is the last 5 questions that I ask of every person who has been on the show thus far.
Okay.
So, what is your favorite procedure to perform and why?
It is totally random. I like distal biceps tendon repair.
Really?
Yeah, I don't know why.
Okay.
Yeah. There's just tendon surgery to me is the epitome of sports medicine. I mean, aside from fractures, fractures are awesome. There's still something really great about an ankle fracture. I'm sorry, and that's, I hope I never give up doing those.
Right.
And I really like our quarterback, who just was named the offensive MVP of the league, had an ankle fracture last year, and trying to explain to people that that was sporty.
Yeah.
It was real nice. But aside from fractures, which obviously is the true epitome of orthopedics, this is the epitome of sports medicine, is tendon surgery. And there's just something about tendon torn, tendon fixed that's phenomenal. And it's just so slick.
Yeah.
Have we done any?
No.
Oh, it's good.
Oh.
Yeah, so it's nice. Yeah, it's especially when they're really retracted up the arm, you find the little worm of a tendon, you pass it back down there, you drill a hole. It's so simple in the technology.
Right.
We're not doing sponsor stuff, but just using the concept of using a button.
Yeah.
How genius that is. It is the simplest thing out there, but it is so powerful.
Yeah.
It's putting a screw and it's just, I don't know. It's slick, it's nice, it goes well. Patients do really well, and and honestly, because I work in because we're in an academic institution, I think it's nice as everybody gets to see, the resident can see it, everybody's involved. It's a nice, simple, straightforward, very principle-based surgery. So. I told you it's random.
No, I support it.
Okay.
Second question. What are your go-to topics for Grand Round presentations?
All right, so I thought about this one a little bit, a couple different ways to go. But what I settled on is...
There's no right or wrong answer.
No, but I mean, it's, understood. No, so perhaps this is more like what my favorite Grand Rounds presentation that I've given has been. And it started, so it was a conversation, kind of a PRP update.
Oh.
Okay, right. So a little bit sporty.
Yeah.
That's where it came from, and that really was.
I remember that one.
Yeah.
That was so good.
And it's really where, that's where it started from. Was I do sports medicine. Let's talk about PRP to a bunch of academic orthopedists who don't necessarily know much about PRP.
Right.
That was the goal.
Yeah.
And just kind of residents, what is it? Otherwise, update, where are we? And what it became that I thought was really interesting was much more of a conversation, almost an ethical conversation, about where we are at with the data behind this and how that governs what we present to patients as their options.
Right.
And how, when you look at it, when we all know the reasons why it's very, very difficult to study PRP, and we also, I fully admit, we don't have not even slam dunk data. We don't have consistent data saying what it does. We don't know what in there is working. Obviously, we have no dose, any sort of sense of dosing, all of this. So I completely understand and agree, like, all of the problems. It is an extraordinarily hard thing to study. But then you look at so much else of what we do in orthopedics doesn't have great data behind it.
True.
And you look at things like viscosupplementation, and, you know, which we have data for the old guys with, you know, with arthritis. I think a lot of us in sports medicine, I use it all the time for patellofemoral pain. And there's just a well-done study that came out that isn't supporting us in it. And we all thought it was going to be great because anecdotally it works. I have so many student athletes who use it, and it works great. They couldn't live without it.
Wow.
But we don't have great data behind that. Yet we don't have any problem. No one in the audience has any problem presenting that as a little bit of an outside the box, but an option to their patients, because in many cases we can get it covered by insurance. And then we come around to something else that requires out-of-pocket expenditure and may not have, we can argue the tit for tat of how much data is behind it, but really the downsides of it are almost purely financial. And how many people in that audience, our faculty members, would be unwilling to have that conversation as part of a complete conversation about what the treatment options are for any of the indicated pathologies? You know, basically nobody said they would bring this up to their young patients with early knee arthritis. And so what is that? Long way from our little sporty PRP topic, but it became something really interesting that so we are now assuming judgment of what our patients want to know about and what it's worth it to them.
Right.
And I loved
it. It was so cool.
It evolved, and it was something now that actually comes up a lot. And when I'm then talking about it to patients, I actually often will talk about this, that, you know, look, I know that this may not be an option for you, but I think it's important for you to understand that this is out there. Here's what we know. We'll educate you more in terms of deciding whether or not this is worth it to you, because it does have a different cost associated with it. It's not just a risk cost, which was lower than almost anything else we give these patients. But there's financial, but it's not our job to assume that risk-benefit analysis for our patients, I don't think. So anyway, so that's my favorite grand rounds.
I know that. I had such great, because I remember I was an intern when you gave it, and it like blew my mind, because that it was very organic too. Like it was so organic how this whole thing spewed off. And I was just like, oh my God, this is amazing.
And it was the older generation front left corner. That just, and you just saw that is, we don't do this, and it was you shouldn't. It was interesting.
It was awesome. Question number 3: what is your favorite story / memory as an orthopedic surgeon? This is always the toughest one.
I know. Well, I don't know that, but I gotcha. We have to do this in order.
No, we can come back to it.
Let's come back to that.
We can come back to it. All right, next question. What are your favorite activities outside of the operating room and outside of medicine?
So I'll caveat this with the fact that balance is not my forte. So certainly, I mean, outside of the operating room, it's the same thing. But I love talking to patients. I mean, I run horribly late in my clinics all the time because I get chatting, and I like to I like to talk to patients about what they like to do. And to me, I am essentially a preserver of quality of life. And so I love those most of the time. Love those conversations. And so that's outside the OR, and maybe that's abnormal for a surgeon to like that. It certainly doesn't lead me to cranking patients through clinic efficiently. But I love that aspect of medicine. And then that comes, I guess that then translates, certainly athletically. I mean, what I love most about my role with Yale Athletics is the relationships. To me, it's just about the relationships. It's not about the surgery. It is about getting to know those kids and supporting them in their dreams and getting them to know their families and, and honor. I mean, I suppose in some ways this is, I don't know if favorite students doesn't become a memory, but shoot, I was trying to double team these.
You can if you want to.
No, it's okay. But I mean, just how amazing it is every time you talk to a kid or a parent and they, you really realize that you have built that relationship with them.
Right.
And how it allows what we then can do when you have that trust, that we now get away from the cookie cutter textbook medicine and start to have the fun art side of athletic medicine, which is awesome. I mean, and that to me is when we get to do something that's a little bit outside normal and push the boundaries a little bit. That's it. Like that is the biggest, that is my favorite thing. Outside of medicine, I think like all of us, I like being outside, I like being active.
Right.
I don't run as much as I used to, but whether it's, skiing, I grew up in the mountains, and so just being outside and hiking and that's
outdoors.
Outdoors.
I support.
Yes. All right, do you want to come back to number 3?
Yes.
Okay. So, in terms of my favorite memory as an orthopedic surgeon, it was it was well publicized. So, 3-4 years ago, was kind of back as we were talking about just really starting to find a place within athletics where I could make a name for myself and just do things the way I thought that they should be done without anybody else kind of tinkering, and started spending a lot of time with the men's lacrosse team here, who was good. They'd been terrible when I was an undergrad, and all the guys have a hard time, the guys who now are national champions have a hard time believing that when I was here, when I was playing, we were the lacrosse team on campus, and now they're national champions. But it's a good thing to remind them that things ebb and flow. So I started spending a fair bit of time with them, and it's contact sport. It's, we'll play on turf. And one of the early games that I was at, one of our defenders went down. And I don't know who these guys are very well. But, comes off, evaluate him, and it's one of those like sideline obvious ACL tears. Right. And the way the coach is looking at me, the way the athletic trainer is looking at me, I'm going to start to realize that like this kid's a big deal, and he ends up, he's a first-team All-American. He's our captain. We have one captain at Yale, and he's it. And to this day, one of the most amazing people I've ever met. And he looked me in the eye at that point. He's a senior, and he's like, "I'm going to play." And I'm new at this. I am the low man on the totem pole, and we haven't done this before. And so what we basically let's not get ahead of ourselves. We're going to get an MRI. We're going to understand where we're at. We got to get you feeling good. This knee's going to swell up. So we kind of go through this whole process, and that was 6-8 weeks before the end of the season or so. And basically, as we end up progressing, built an extraordinarily close relationship with his parents and with his family, and just came to learn like what an amazing guy, young man that he was, and what his aspirations are, and how much lacrosse meant to him, and really got to have one of the best risk-benefit conversations you're ever going to have, and that was to sit down there with a senior student athlete a few weeks away from the end of his season one way or another, and talk about what we were going to do about this, because if there's no surgery and coming back from it. We don't do red shirts. It was too far along in the season. And ultimately, we decided to allow him to progress along a return to play protocol. And so we had all the same normal benchmarks that you have to hit in order to come back from an ACL reconstruction surgery. And there were lots of raised eyebrows medically from a lot of people who are, older than me and just had different kind of opinions, but kind of kept checking in at all points along the way, said, look, there are risks to this. There are benefits if we pull this off. And ultimately, so we got him back out on the field, and he not only played, he was spectacular. And on his senior day, all of his parents came, his parents and his grandparents, wonderful big family, came on down to the field. I'm just kind of standing there on the sidelines as I am, trying to stay out of the way. And his grandmother came up and found me, who I had not met, came up and found me, gave me a huge hug, and thanked me for allowing her grandson to be back out on that field. And I'm not an emotional person at all. And to this day, when people kind of ask me how I knew that that was the right thing to do, it was at that moment.
Yeah.
There was no, when grandma comes up and you've built that kind of relationship and that kind of trust with the family for a non-surgical
non-surgical management.
Non-surgical management. That's it. Like, that is everything I wanted to accomplish in sports medicine, and frankly as an orthopedic surgeon, was to be able to look at this and know that the textbook answer to this was one thing, but there's a conversation around everything. And knowing and taking the leap of faith. And that started because I had a good relationship with the kid and with the athletic trainers and with the coaches and with everybody else. And so every step of the way, we paused and we made sure it was still the right decision for everybody involved and did not proceed blindly, but we kept moving along. And with that grew the mounting evidence that what we were doing, medical evidence that what we were doing was right. His stability was back. We, ran him through motion capture and ran him up and down the field and watched, and he passed all of his return to play tests. We had that objective evidence, but still, anybody who wants to question you can question you at any point, and you get right into that, fall back into your, imposter, not even imposter syndrome. Anybody can question you for playing a kid with an ACL tear. But knowing in the end what a difference that made. We're sitting here having this conversation with, this picture that he gave me, of him playing in that last game out there. And we're still incredibly close. Because that gave him back, his senior year, and he got to finish on the field in the way that he wanted to. And he was the best player on the field in his last game.
That's an amazing story.
Yay.
Oh, Dr. Gardner, I had no idea.
Oh, yeah.
Yeah. Wow.
Yep. Yeah, he's such a badass kid.
Ugh.
I love that kid.
That's awesome.
Yep.
All right. Last question.
Yep.
What advice do you have for orthopedic surgeons and orthopedic surgeons in training?
Generally.
Generally. Or specific, whatever you prefer.
So, I think it probably has, and again, we've talked a little bit about just kind of a style and how much, again, I very much feel this is a relationship position, and we're about quality of life. And so I think a lot of times, and perhaps it's because of the meathead stereotype of orthopedists, and that certainly is no longer true most places. We don't look gender-wise a whole lot less big meaty guys in orthopedics. There's still plenty, but things have grown and we've evolved as a field, and we've become, much more academic and that. But I think that remembering that what our goals are and what our goals are need to be aligned with what our patients' goals are, and that means you got to talk to them.
Yeah.
And you do have to. We tend to get the bone broke, bone fixed. Looking at the imaging and knowing that we already have our indications set. And I like that we're very practical sometimes, and that becomes very clear. You gotta.
Right.
But that's not true most of the time. And I like that, when you're taking consults with Dr. Baumgartner, right? He wants to know things, it's how many stairs they have in their house. But then it's, do they balance their checkbook? Has he ever asked you that one?
No, not yet.
So just these, who are we dealing with? You're coming to talk to me about a tibial plateau fracture or an ACL or a rotator cuff. Who's that attached to?
Right.
Who are they? Because I lead almost all of my likely pre-surgical conversations with this, that a lot of people kind of look at me, but I'm like, no one's ever died from this.
Right.
Ever. From an ACL tear, from a rotator cuff, from a meniscus, all of these things that people think, I gotta have surgery, I gotta do this, I gotta do that. We are incredibly lucky that we don't, outside of tumor, and there are, obviously there are things that have very strict indications, but in general, we get to work with our patients to optimize their care for what they want to do and what their goals are. And sometimes that means being extraordinarily aggressive in something that normally, athletic wise, yeah, sometimes, I've done some surgeries on, athletes of, cleaning up tendons and just things that but for them, that enables them to do what they love to do and what they need to do. They need to get from 98 to 100%, and that 2% matters to them. Whereas in other patients, it just may not, and the risk of surgery and the time away from work or the time away from their life or gardening or whatever it is that you're going to take from them in exchange for getting them a whole lot more than that 2% you're getting that athlete, in your mind, may not be a worthwhile trade at all for them. And so I think it's keeping that in mind. It's something every one of us has to remember every once in a while, because we're lucky we get imaging, we get a lot of pictures to look at, and you think you got the whole story walking into the room. And reminding ourselves that our job is to match the right treatment with the patient. And again, I think that's why, we need to make sure that we are not just surgeons. And we don't want to be viewed as just surgeons, because we have all of the options in our armamentarium. We are the only ones who span all the way.
Right.
But if we don't remain experts and remain excited, to talk about and to find those non-surgical options when appropriate, we're not doing anybody any service.
Yeah. Dr. Gardner, thank you so much.
Thank you. This was amazing.
I know. This was awesome. I hope everybody enjoyed this episode of the She Can Fix It podcast with Dr. Liz Gardner. Please subscribe to our podcast on Apple Podcasts, Spotify, Stitcher, Google Play, or YouTube. You can find us on the web at shecanfixitpod.com. We're on Twitter and Instagram at shecanfixitpod. Finally, I want to say thank you to all the listeners who are taking the time to listen to our podcast. I know we are all very busy people, so I do sincerely appreciate it. Please subscribe to wherever you listen to your podcasts. Please also spread the word. Tell your friends, your mentors, your medical students. If you have any questions or would like to hear a friend, mentor, legend on this podcast, please feel free to email us at shecanfixitpod@gmail.com. And finally, many, many thanks to my editor and co-producer, Andrea Vannie Kirk, without whom this podcast could not be possible.